Okay, we're going to talk about cardiac arrest in renal failure patients, dialysis, emergencies. First of all, you have to have a high index of suspicion for renal failure. Many times, if these people are comatose when you get on the scene or they're in cardiac arrest, you're not going to know that they have renal failure unless you do a good history, physical exam, get information from the family. It's easy when we respond to a dialysis center. We know that they're a dialysis patient, but many times we're going to have to actually ask the family or friends that are with it, hey, do they have renal failure, etc. Cardiac arrest in renal failure patients many times are related to hyperglycemia. Renal patients can certainly tolerate an elevated potassium more than a normal patient, but still it can certainly be lethal and cause problems as that potassium continues to rise. Many people will tell you that a potassium level over 9 is pretty much lethal. And again, history, have you missed your dialysis? And many patients on dialysis are non-compliant. And we need a good history. Have you missed dialysis for the last several days? At your last dialysis session, did you go the whole time, etc. So high index of suspicion. Many times on an EKG, we can get an indication that the potassium is starting to become elevated some. Peak T waves we've always heard of. Those are something that you need to look for, but that's a non-specific sign, to be honest with you. As that potassium continues to rise, then we get the sine wave. If you remember, it's just almost like a wave. That means imminent death. Those patients are getting ready. If they're not already in cardiac arrest, those patients are getting ready to go into cardiac arrest. That is a pre-arrest rhythm that you need to do something very quickly. If not, the patient's fixing to go into cardiac arrest. And then after the sine wave, if you don't catch it in time, you don't treat them, then they're probably going to deteriorate into a ventricular fibrillation. So what's the number one treatment if you see that patient that starting to get peak T waves, they're in a sine wave on an EKG? In the pre-hospital area, we don't have the luxury of having medication. We don't have the luxury of having an I-stat or chemistries that we can say, what's the potassium. So I think it's again history and physical exam. If they're starting, especially if they're getting into that sine wave or they're already in cardiac arrest, we carry calcium, we carry bicarb. Calcium is the number one drug that we need to give pretty quickly. Calcium is a drug that really won't move potassium. If you remember back, and we've talked about this before, potassium inside the cells really don't cause much problem. Potassium in the bloodstream, that when it moves out of the cells into the bloodstream, that's where the potassium becomes dangerous. So we try to move that potassium from the bloodstream intracellularly, which will, for momentarily, will make that potassium less of a problem. Bicarb is another medicine. It will actually move that potassium intracellularly. Calcium doesn't move it, but what calcium does is it stabilizes the membrane. If you think about hyperkalemia, the cardiac membrane is just very irritable. And if you remember back to your physiology in the past, an irritable cardiac membrane can lead to VFib, VTAC, etc. So we want to stabilize that membrane. Well, calcium stabilizes the membrane, and then bicarb will actually move that potassium intracellularly. Now again, we don't carry some of the medications in the pre-hospital arena that we would use in the emergency department, but just as an aside, D50 and insulin. Insulin will also move that potassium inside the cell. So we give insulin, but we also have to give D50 to keep the blood sugar from dropping. Albuterol updraft a neb treatment can actually move that. Now we do carry that. If they're still awake, still alert, we can certainly give them a neb treatment. Kayexalate is another medication that you may see us give in the emergency department. All those are medications down the line. I think the two biggest things are the two main medications that we need to use in the field is one, calcium, and number two, bicarb. And what about calcium gluconate or calcium chloride? If you look at a lot of the protocols throughout the nation, many people will not use calcium chloride unless they've got a central line. I think in the hospital that's fine, but in the field we don't have a central line. So I think calcium chloride, if you don't have anything except calcium chloride, is fine to give through the IV, a peripheral IV, emergently. Just as an educational point, calcium chloride contains about 3 times as much calcium as calcium gluconate, but you can use calcium gluconate as well. But again, bicarb and calcium are two drugs that we need to really think about giving. Many times these people are very difficult IV sticks, and we may not can get good IV access on these people. There's always a question, what can I use the dialysis catheter, either a permacath or a vas cath, or can I use the AV shunt? And the answer to that is, in a cardiac arrest, absolutely you can. Now what I would try to do before is I'd certainly try to get IV access, and if I couldn't get IV access, I'd certainly think about an IO access. But if all of those fail and the patient's in cardiac arrest, then you can certainly use the AV shunt, you can certainly use the permacath or vas cath. Again, would contact medical control and talk with them about this, but in an emergency you certainly can do that. And again, the vas cath or the permacath in the chest or in the neck, obviously they have caps on the ports, and you can use those, maintaining sterile field or sterile technique. Those catheters have heparin in them, so once you draw the blood out, 10 cc's, waste that because it's got heparin in it. AV shunt, stick that. Again, those are things that are down the line that I think we can most likely get an IO line in them, but certainly something that we can consider use, but I would contact medical control. I would not use those dialysis catheters for just routine IV access on a patient that's awake and alert and vital signs are stable. What about dialysis catheter malfunctions? I know many times we will see those dialysis, especially the AV shunts in the arm or the leg, bleeding. Many times we're called to dialysis centers because they're bleeding. We're called to the patient's home after they've returned from the dialysis center with bleeding. If you're called to the dialysis center, they've got the basically a band that they put on that's a compression dressing that many times will stop the bleeding, but if it doesn't, you may be called. Keep in mind that you can lose a lot of blood from a dialysis shunt, so you would treat that like any other external hemorrhage. You may even consider tourniquet use. You can consider hemostatic device use, direct pressure. Obviously you can elevate. So keep those things in mind that if you can't get the bleeding stopped, then you can certainly consider a tourniquet just like any other major bleed, hemostatic agents, etc. Dialysis emergencies, unfortunately, are something that you're going to see more and more of. We're seeing more and more people on dialysis. So again, I would familiarize myself with dialysis emergencies, and I think this is a pretty good overview and some of the take-home points. You got to have a high index of suspicion. Many times these patients are in cardiac arrest when you get there, and you really won't know, but you can see an AV shunt in their arm or their leg. You can see the permacath or the vas cath in their chest. Most of the time the families can tell you. It's real easy when we go to the dialysis center. and they tell us, obviously, patients on dialysis and gone into cardiac arrest. Hyperkalemia is the cause of many of these cardiac arrests. Again, if you don't catch it early, it goes into that sine wave, which can deteriorate into VFib. Calcium stabilizes cardiac membrane, and bicarb moves that potassium inside the cell, which makes it less active. And then again, external hemorrhage from the dialysis catheters, treated like any other hemorrhage. Thank you very much.